Hi, my name is Mike Tuchek. I'm going to show you a case of an abdominal aortic aneurysm that I placed an endovascular stent graft using the Volcano intravascular ultrasound. On slide 2 you can see this is an 82-year-old male who had a past medical history of high blood pressure, hyperlipidemia, and he was a smoker. The CAT scan showed a 5.3 by 4.6 abdominal aortic aneurysm. The next slide shows a CT image of that AAA. I start my cases putting the intravascular ultrasound up the left side and ultimately the right side, which you can see here. And on this slide you can see the intravascular ultrasound pullback, which clearly identifies the celiac, superior mesenteric artery, the renal vein along with the takeoff of both renal arteries, the aortic neck itself, both the length and diameter and the quality of the vessels, and then the aneurysm itself along with the amount of clot you may see there, and then the common iliac artery, both its diameter and the takeoff of the internal iliac artery, and then the diameter of the external iliac artery, so I can decide which side to put the main body up. The next slide shows that the aortic diameter is about 24 millimeters, just below the renal arteries. The next slide shows that it narrows down to about 19 millimeters in the distal neck. And finally, right above the takeoff of the aneurysm itself, it's about 22 millimeters in diameter. The next slide shows the left common iliac artery that's about 14 millimeters in diameter. I then can place the intravascular ultrasound up the right side and confirm all of those measurements, but especially I'm looking at specifically the common iliac and external iliac artery diameters, which you can see in the next few slides show that it's about 14 millimeters in diameter in the right common iliac artery. So all of these questions listed here I can answer with intravascular ultrasound pullback, which takes only a couple of minutes to perform. I have not used any contrast and I've only done a couple of spot fluoros at that point. The Volcano IVUS tells me that I need to use a 28 main body graft, that I have about a 2 centimeter neck, that there isn't a lot of clot or calcium or debris there, nor is there a lot of angulation. So it looks like a fairly straightforward neck. I should land it essentially right at the takeoff of the renal arteries. Question, do you need a grafted suprarenal? In this case, you could use an infrarenal or suprarenal device, but I prefer to use the Medtronic Endurant device for suprarenal fixation. And of course, is there any distal aortic neck stenosis above the aneurysmal segment that's going to interfere with gait or the cannulation of the gait or the device itself? The answer clearly is no, there's not going to be a problem in this particular case. The next slide, the questions that we ask: how big, long, angulated, and diseased are the iliacs? In this case, they're not terribly diseased. I know what the length is based on spot fluoro measurements and the 1 centimeter markers on the IVUS catheter itself. I know both the ipsilateral and contralateral limbs with 2 quick IVUS runs. I don't think there's any significant iliac stenosis in either the external or the common, so I don't need to do any pre-ballooning or dilator sheaths, etc. And I know the diameter and how diseased the externals are. In this case, I chose the right side for the main body device. The next slide here shows the aneurysm itself with the nice neck above, somewhat tortuous iliacs. This next slide shows the 2 centimeter neck below that right renal, which looks very straightforward, no significant stenosis on angio, but we've already confirmed that with intravascular ultrasound. The next slide shows the deployment of the Endurant device just below the renal arteries. The next slide shows after we've put the wire inside the gate, and of course to confirm that the wire is in fact in the gate, you can either spin a catheter there, or you can do an exchange and put a pigtail up, which takes time, or I just put the intravascular ultrasound up if there's any question, and you can see that run here, and clearly I'm inside the gate, no question about it. The next slide shows the angiogram of the left iliac, and I show that for demonstration purposes only. I normally would not do this during a case. I would simply identify the internal takeoff where you see the IVUS is actually at right now, and then use the marker catheters built in to decide how long the iliac limb extension needs to be. The next slide shows the IVUS pullback of the left common and external iliac arteries to identify those structures. The next slide shows the endurant limb after it's been deployed, extending it just down to the internal iliac artery takeoff. The next slide shows the right internal iliac artery takeoff with the angulated common iliac artery. Again, this was for demonstration purposes only. I normally would just mark the internal based on where the intravascular ultrasound identified it with a spot fluoro, and then deploy down to that point with the graft. The next slide shows the endurant limb after it's been deployed with the intravascular ultrasound catheter inside of it to check for any iliac limb stenosis at that area of angulated iliac. The next slide shows the IVUS pullback on the right side, which shows the internal iliac artery takeoff and the graft deployed just above it, so that we know we nailed the area we wanted to, just above the internal, that there's no common iliac artery stent graft limb stenosis, and up in the neck that the graft has no graft infolding, and it's just below the renal arteries bilaterally. The next slide shows the iliac limb extension after it's been placed, and shows the ballooning in the next slide. And using the reliant balloon throughout the rest of the graft in the next slide. And in the final slide, you see the angiogram with the nice long neck, the stent graft in place with no significant limb stenoses or kinks on angiogram, which we've confirmed by intravascular ultrasound, and we know we've gotten right down to the takeoff of the internal iliac arteries bilaterally, both on the final angiogram, which is sometimes difficult to see because it's an anterior-posterior picture, but certainly we confirmed that by intravascular ultrasound, as you saw above. These last two slides in conclusion showed that the IVUS helped me identify key anatomic landmarks, renal arteries, the internal iliac artery takeoffs, etc., the extent of the calcium, how much stenosis or debris is in both the aortic neck and or the iliac arteries. In the last slide, it also helped me make key decisions about graft sizing, graft length, the location and placement of the device proximally and distally. I wanted to make sure I hit the renals right below that area and, of course, right above the internal takeoff bilaterally. Most importantly, however, it really helped me reduce the amount of fluoro time and overall time doing the procedure, because I don't have to have unnecessary multiple catheter exchanges for the marker pigtail and the time spent doing additional angiograms. And because I don't have to do those additional angiograms, it allows me to do a case with significantly less contrast for identifying structures, which I can see easily by IVUS. I typically do a run or two just to identify the renal arteries at the beginning, which is 20 to 40 cc's total, and then a 40 cc run at the end of the case. So I average 60 to 80 cc's of dye per case, and with rare exception, I can place the device and get great results thanks to intravascular ultrasound. Thanks very much for allowing me to present this case.